And so, yeah, Dr. Decker, I guess moving on, because I think this was good. We spent a little time on the B1s just because, I don't know, we could talk about them all in general in some fashion. But moving on to like the B2s and B3s, kind of what things are you thinking about when you taking this to the OR?
Yeah, these are of periprosthetic fractures. I think these are my favorite. These are tough cases. Uh, B2s, I think a couple of things that one thing I didn't hit on before, and I think you ought to consider cemented stems and how to assess their stability. A cemented stem that has a fracture through the cement mantle, I would assume to be loose almost invariably. Whether that be a slip taper stem or a composite beam stem, they're so reliant upon the intact cement mantle for stability. If there's a fracture in the cement, it's a loose component. Just something to touch on real quick as we get into this one. B2s are really they're tough cases. There's kind of two ways to handle them, and it depends a lot on the overall fracture pattern. These are different in the approach that I often have. You have to open up the whole fracture site typically, and you've got to try to recreate some type of tube, put the femoral diaphysis or metadiaphyseal region back together in order to get a revision implant in. You can do it two ways. The implant's loose, so you're taking it out. And then you've got to go about figuring out if I'm going to put the femur back together first and then put a revision implant in, or if I'm going to put a revision implant in and then fix the femur. And that really depends on whether or not you think you can get an anatomic reduction of the femur. In highly convoluted fractures, where it simply doesn't appear to be a viable option to get true anatomic reduction, which thankfully isn't as common, you want to probably put in your revision implant first, and then you can essentially, for lack of a better term, cobble the femur back together around the implant and cable it together. Because you're relying on the distal intact bone for the fixation of your implant. The more common scenario is you can put the femur back together, and then you can actually put your revision implant through that. If it's an anatomic reduction, you can actually put a slightly shorter stem in where you don't have to get quite as much distal fixation. In terms of what you do for your revision, the important thing to remember here is that your revision implant is not a primary implant. Your revision implant is engaging and getting its stability from distal integration. You can do that either with what is probably the most common 95+% of the time, I'd say people are doing some type of fluted tapered titanium stem, whether that be a modular or a monoblock version, or you can do something like a cylindrical, fully porous coated stem. Both of them work great. I think less technical complications with the fluted tapered titanium stems, but both certainly can work for situations like this. And you really want to make sure of the really important principle. I'm sure this still comes up on tests, is the amount of distal fixation that you need in order to consider it adequate. The test answer to that typically has been about 4 centimeters of scratch fit of the stem distal in the intact femur. Certainly people are pushing that limit a little bit, sometimes even going as little as 2 centimeters of scratch fit for fixation, but I believe, the test is still asking it answer 4.
When you say scratch fit, what do you mean?
Yeah, so scratch fit really is how much, when you get cortex to cortex, or you're basically getting full a fill of the stem distally in the intact femoral diaphysis. So you want to get out to cortex, and you want 4 centimeters of contact between that stem and cortical bone distal to the fracture.
Got it.
Okay.
And I think that's so, that's something you're going to see on all the questions. They always mentioning about, you're pretty much trying to get your fixation distally now. So you see the modular fluted stems and the extensively porous coated stems. Yep. So very key. I think most times when you see these bad fractures, the answer is going to have something about a long tapered stem, because you got to pass the fracture and you're trying to get your fixation distally. So,
and again,
yeah.
Now I just had a quick question for Dr. Decker. Is there anything that, I know we were saying, you could choose either or, but is there anything that has you go, one way towards a fluted taper stem versus a cylindrical? Like, is there anything that has you choose one versus the other? And then I guess, is there anything that's better or, high yield to know about each one?
Yeah, I think that's a really good question. I think generally speaking, most of the arthroplasty revision work being done now in these situations is being done with fluted tapered modular stems. And I think it has a lot to do with the fact that those stems offer a little bit more flexibility and probably a little less fracture risk in terms of propagating a distal fracture in the diaphysis than a cylindrical stem. Cylindrical stems are interesting. They have such a great track record for fixation. They really do work great, but I do think they're a little bit more technically demanding, and there's some variations in the actual diameters of the stem distally because of that porous coating, how it's applied. So you might ream for a 16, but your stem might be a 16.25 or a 15.75, and you actually have to measure that out before you put it in. So I think knowing that those fluted tapered stems have modularity options, a little bit more flexibility in terms of, a little bit more consistency, I should say, in terms of the diameters and the geometry of the stem. I think that generally speaking, I would almost always use some type of fluted tapered titanium stem. Monoblock versus modular is really dependent upon bone quality. So I tend to use modular, but patients have a lot of proximal bone loss. And I think that's important in those B3s where you've got all that bone loss. I worry about leaving an unprotected junction or where you've got a taper proximally. Anytime you've got a modular interface, you've got a risk. They can always fail. Though it's rare, they can still fail. So if there's no bone up top or on the top of that femur, right where that junction is of the modular bodies of those stems, I'll put a monoblock in just because I don't want an opportunity to have a failure at a junction.
Okay. And say with the B3s, so say with the B3s, you say that's when you're starting to think about doing the monoblock. So okay. And just to be sure, is the monoblock like the allograft? Like the allograft struts?
So my apologies, the monoblock, a monoblock fluted tapered titanium stem, essentially imagine a modular version like on your previous slide, but instead of having a separate distal part of the stem and proximal part of the stem with that bolt that pulls them together and that Morse taper, it's just one stem. It's one giant block.
I see what you're saying.
Yeah, so you get rid of that junction, which is nice, I think, for just for rigidity there and to decrease your modular interfaces. So that's what I tend to lean on that stem a little bit when there's more bone loss.